Hey guys, Tom here from Foam Frat. Welcome back to new research review. We did a little work since our first one and took some feedback and decided to rename it Retrieval Research. So we're going to be diving into some more research articles. So again, if you come across an interesting article, you want us to take a look at it, want us to give it a review, send it on over to team@foamfrat.com. So a couple other new things. We are now going to include guests on the show and have some good discussion. So, got a good friend here tonight, Mike Brown of the RSI podcast, as well as Foam Frat. Mike's a great guy, and I was lucky enough to be on the RSI podcast a few episodes ago when we discussed the COVID vaccine. So, Mike's kind of a subject matter expert in a lot of what tonight's article is about. So, I'm really happy to have him here. And the other thing is, if you head on over to foamfrat.com, if you check out the website, we made a couple changes, and if you click on Friends, it'll take you down and show you the RSI podcast, Retrieval Research, and Good Reads with Jake Good. So a couple new shows from Foam Frat for you to check out. So the article we decided to take a look at today is a fresh article out of the New England Journal of Medicine, just published within the last few weeks. Got some traction on Twitter with some interesting discussion from some airway enthusiasts, and it's on management of the difficult airway, and it's by Thomas Heidegger, and it is really a review article. So, a lot of the articles we're going to be talking about are kind of prospective and retrospective research studies that we're looking at a specific trial and saying, what did we learn from this? How can we critically evaluate it? What are the statistics? Is it valid for our setting? But a review article is going to be a little bit different for us. So a review article is, we're just kind of diving into the research that's already out there and saying, what can we learn from that overall? And this one happens to cover a lot of the things that we encounter from an EMS standpoint, where we deal with a fair number of difficult airways. So, and we train for difficult airways. Many people are involved in difficult airway courses, difficult airway continuing education, and we have different focuses. So, focusing on physiologic aspects of the difficult airway, anatomic aspects of a difficult airway, and one Mike is really passionate about is human factors. My question for Mike is, we both seem to have different takeaways here from what we got. We thought the major point was that resonated with us, which I think is kind of cool, because this article really encompassed so much. So, Mike, what was your main takeaway and your main message that you got from the article?
Yeah, thanks, Tom, for having me. I really appreciate you having me. And we're recording this right after the Memorial Day weekend, so I wanted to say, I appreciate those of you that families that had a person who made the ultimate sacrifice, and that we memorialize the sacrifice that they did make. So just wanted to give you a little shout out there and recognize that. But this really was a great article, and I really enjoyed reading it, and I think there were a lot of good takeaways. But something that really kind of smacked me in the face a little bit, and one of my passions, anybody that talks to me knows, is human factors, and um, I think that's something that's really kind of lacking in this. They try to just kind of scratch the surface of it at a few points, and then round out the article with about 2 paragraphs talking about human factors. Yeah, they dig into NAP4, the National Audit Project 4, out of the UK. I've used a lot of that data in talks that I've done, and it's some great data. I enjoy being able to use it, and it really draws some good conclusions. But it tells us a lot about human factors, and one of the things that I think is very telling that we take away from NAP4 that is mentioned in this article. Hold on, I'm just getting to the exact number. So it's human factors contributed to 40% of the serious airway complications and were major factors in 25% of those. So a quarter of the complications that were caused by human factors were a major factor, and it encompassed 40% of the issues that were experienced. And that kind of segues me right into my other big takeaway from this, and then I'm going to shoot it back over to you, Tom. And that's that I don't. I think we put a lot of time, training, techniques, equipment, everything else into management of the anatomically difficult airway, and I don't think we give nearly the respect that we should to the physiologically difficult airway and the resuscitation phase that has to happen before that airway management takes place, and preparing that patient for transitioning to positive pressure ventilation after we do take that airway. We talk a lot about looking at airway assessments. There was a systematic review that they did discuss in this article. Numerous participants, 840 plus thousand participants, concluded that none of the current bedside screening tests alone or in any combination were suited to detect an unanticipated difficult airway because they missed such a large number of people with those difficult airways. So that leaves us reactionary to these difficult airways when we know that physiologically we're likely going to experience issues. And when we turn to reacting as opposed to staying action oriented, it affects the amount of discretionary time that we have for making decisions. This is a time compressed environment where we need to make decisions very quickly. So any discretionary time that we can pull out of that is so important. So I'll kick it back to you, Tom. Thank you.
Mike, that was an awesome takeaway from this article because it really did, kind of hit on so many factors that affect an intubation. But you really nailed it with the human factors and the analysis they looked at with the difficult airway predictors, because most of us have been taught the lemon mnemonic or the Mona mnemonic for difficult bag valve mask ventilation, and stuff doesn't necessarily lead us to predicting that difficult airway. And I think a lot of the experienced clinicians listening to this, we've been in that scenario. You get a patient who you're like, this is not going to be a difficult airway at all, and that even in a controlled environment, that happens in the operating room. Anesthesia does a really good preliminary airway assessment prior to taking patients back to the OR for elective surgery. And when you talk to pretty much any anesthesiologist, they're like, yeah, I've had plenty of airways where I had predicted an easy airway and I got in there and it turned out to be super difficult. So even the experts from a human factor standpoint, still encounter difficulties that they can't predict with their daily prediction tools. So from a human standpoint, and kind of developing expertise as well, is that tells me that even the experts encounter the unexpected. So my question from the human factors perspective then is, how do they manage that, and how do they prepare for it? Preparing for the unexpected. And I think EMS, we've done a pretty good job in some ways implementing checklists, implementing mnemonics we use in preparing for intubation. But a lot of our algorithms, including the algorithms in this article, and that was one of my takeaways here, is something you mentioned. The physiologic aspect is aligned. So pre-oxygenation is one line of some checklists. Managing patient positioning is one line of a checklist, and even optimizing physiology itself with fluids and pressors and blood tends to sometimes be one line in an algorithm, but then a lot is focused on equipment factors and predicting difficult airways, and having what do I do for my second attempt, what do I do for my third attempt. So I love having plan B, plan C. I communicate it with my team, but my reflection on this is I don't know if I necessarily communicate with my team as much as I should on what else do we need to do to physiologically optimize this patient before we proceed any further. So that way I'm in a good position to move forward with the rest of my plan. And I thought this article was interesting overall, in a way, because it focuses a lot on anatomic difficulties, um, in light of the number of physiological challenges that we encounter. So that, from a review perspective, leads me to think about two different things. Is it that a lot of research is done on the on the anatomic factors, as opposed to, I think the physiologic factors are something that may not be studied as much in the emergent setting. I don't have a good number on that. I don't have a good answer for is that the case or not. But that was one of my thoughts as I was reading this article. So they looked at contextual issues that affected their approach to airway management. And they broke that down into a few categories, because if you're starting with an awake patient, how's that patient behaving? What's the urgency in which we need to establish an airway? What do we have available to us? Do we have VL? Do we have DL? Do we have fiber optic bronchoscopy? Do we have our stuff to proceed to surgical airway? My thought is, if you don't have your plan B and your plan C with supraglottics and the ability to cut a hole in the neck, then should you be proceeding any further forward with taking away a patient's airway reflexes? And what's your availability of skilled help and experience and skills of the primary clinician, is a factor here as well. So my question to you here, Mike, is one of my very good friends and mentors, has used the line, don't teach, we don't learn to play football, or we don't teach people to play football during the Super Bowl. So when it comes to airway management, what are we missing when it comes to teaching people how to be skilled at what they do? And then how, in the absence sometimes of EMS systems that may not see a ton of difficult airways compared to, say, an anesthesiologist, how do we build people's confidence and get them to the level where they're prepared to handle those decisions that do come into play here?
Yeah, that's a lot to unpack there. Real quickly though, I was kind of reflecting as you were talking, how much of that concentration on that anatomically difficult airway do you think is a result of it being so objective and so easy to assess and easy to try to throw equipment at? That's what I seem to think when I look at how that concentration is placed on the anatomically difficult airway.
So if I go back to my first article I ever wrote for Foam Frat, was the EMS research conundrum, and it kind of brings me back to really just starting out with the team. But that article was, EMS loves to study things that are easy to study, and even from the rest of medicine, it's, if something is easy to look at, like times are really easy to look at because they're super objective. But it's a lot harder to evaluate things that are dynamic and physiologic factors. So in my reflection on it, when I read the article and said, why don't we have more on physiology? That is my thought, is, it's harder to study. So for any of the EMS professionals out there who are looking for some good research to do, physiologic factors involving intubation is an area where it's going to be challenging to tackle, but we need more information.
Yeah, bingo. I think you hit the nail on the head there. So to answer the question that you asked of me, in preparing ourselves for these difficult airways, be that physiologically difficult, which hopefully that's something that we're trying to concentrate on, and preparing our team to be able to move through that physiologically difficult airway, is a lot of mental simulation. I think that's very important, because all too often people say, well, I don't have access to high fidelity mannequins, or I don't have access to a simulation center, which I wish that everyone did. And it's my hope that at some point we can get more and more simulation resources available, because we just don't. we don't take a lot of airways, so it's difficult to maintain that confidence and competence, which are two very important things when it comes to airway management. But I think all too often we underestimate the value that mental simulation can take. We can solidify some of the exact same neural pathways in our brains as we're thinking through the steps of taking an airway or moving through that particular resuscitation or procedure, and it needs to be very specific. The more vivid the details, the better the simulation is, and the more it's going to benefit you. And this is going to help keep you relaxed. And that way, when you get to that point where maybe you are stressed, um, a lot of that comes back to the state you're in, but some of that is also how you got there and whether or not you had anything to do with it. So you want to be careful about how much your brain controls your emotions. So by staying relaxed through mental simulation and trying to control those emotions, I think that can help us out a lot. One other thing that I did notice in the paper as I was reading it, I think they do get into some areas of physiologically difficult airways that I think are good to mention. The pregnant patients and the obese patients. So these are a couple of populations where their FRC or functional residual capacity is making them a physiologically difficult airway just from the beginning. So I'll take it straight out of the paper. Maternal mortality from failed tracheal intubation is approximately 4 times as high as mortality from a failed tracheal intubation in the general population. That was from NAP4 data. So that's very telling. 4 times as high. I mean that is just crazy. And similar physiology in the obese patients. Um, so we want to be mindful of that. Obese patients are twice as likely to have a severe airway complication as those who are not obese. Tyler does a talk. You can give him a little pat on the back. He talks about children being just little obese adults, and I think it's an interesting way to look at it because, from an FRC standpoint and physiologically, there's a lot of parallels there and a lot of similarities.
Yeah, Mike, I think that we encounter those patients who their anatomic challenges make them a physiologically difficult patient to ventilate. So I think when we think of obese patients, we really think about how hard is it going to be to position them to to instrument the airway and pass the tube. But what happens after we pass the tube with managing their continued airway issue down to the ventilation standpoint. So, I think it's cool to watch anesthesia do some stuff because they kind of, maneuver patients a little bit differently than we do from the EMS setting. And one of the things they encounter a lot is a lot of the patients they, end up putting head down during the operations. And it's interesting to watch them from a ventilation standpoint is they've got to make vent setting changes because their peak pressures increase as they just take even a normally sized not so obese individual and adjust their body position. So I think from our standpoint, this was very telling with that, especially that high mortality rate in pregnant females. Is where do we have to focus on physiologic factors and anatomic differences together as we go through the process of managing patients' airways.
So something else that I thought was interesting that I took away from this that I think is really applicable to EMS providers, and I see a lot of this. They talk about how a major contributor to bad outcomes in the management of difficult airways were persevering in failed techniques. So you do something and then you make a second attempt using the same equipment, the same approach, and you expect it to be successful. We shouldn't do the same thing over and over again and expect different results. because that's ordinarily not how it works, and we don't want to be playing those odds with a patient that's potentially desaturating or becoming hypotensive in front of us. So it's something else I noticed in here that they point out that I think is really applicable for EMS providers.
So, Mike, on your point of perseveration, I try to do that mitigate that myself through mental rehearsal and as much mental simulation as I can before I end up in one of these situations, so that I can have a definitive plan A, plan B, and plan C. And I think that sometimes our plan A is successful endotracheal intubation, plan B being, hey, I have an unsuccessful intubation, I'm going to go to a supraglottic airway. If that doesn't work, I'm going to plan C is going to be, we're going to proceed to a crike. But I kind of, add a sub plan in for intubation is, do I change my blade? Do I change my tube size? Do I change something else about what I'm doing instrumentation wise? Or, do I optimize something differently between attempts if I go that route? One thing I thought they commented on in the article that was really interesting, is that making, from a human factor standpoint, delay in judging when you need to proceed to a surgical airway and a cannot intubate, cannot oxygenate situation was actually a factor for civil litigation and claims. So even outside of just the clinical realm itself, that decision making has a lot of importance. You need to know when to proceed in that time where, from a human factor standpoint, you have limited discretionary time to think about it. So your preparation for this is what makes you decisive. So I think that you and I reach the same conclusion as the author here, is that we talked about physiologic factors, we talked about anatomic factors, things that were covered in the article, but in our own experience, we found those to be extremely important for successful airway management, and that was the main conclusion of the author as well. Is marrying both of those things up is key, and it's essential to success. So, Mike, anything else? Anything else you wanted to add on the article here?
Not really anything specific, but just kind of overall, I hope that this will get, if you're listening to this and you haven't read the article, I hope that this will get you to go read the article. There are some wonderful pearls throughout it, some great information. And as you get to the end and you start to look through the references, there are some awesome places to go for more information. If you want to dig a little deeper into any of the specific topics, there's like over 100 references, or maybe just shy of 100, I think it was. But some great resources that you can utilize to kind of dig a little bit deeper into this.